picture again, which can help you out to understand the basic pathophysiology of the polycystic ovary. Now I would like to show you some picture. This is, you can see a nice CT scan, and try to see there are small white cysts in the ovary. Sometimes the cysts are too many, so the patient, you can palpate some of the cysts. Sometimes patient may have a normal growth. Oligomenorrhea can be present. Hirsutism can be present. Infertility should be the important point here. Endometrial hyperplasia and cancer can be there. So remember one thing I would like to say, that the important differential diagnosis of this polycystic ovary is, of course, one of the tumor of the ovary, and that is the Sertoli Leydig cell tumor. So we should remember three things to differentiate a Sertoli Leydig cell tumor, a polycystic ovary, and the pregnancy. These are the three things how to differentiate if we see this scenario at the age of 20 years or 21 years. So this you need to practice to discuss about these three conditions. Here I am showing you again a polycystic ovary is a nice ultrasound. You can see that there are numerous cysts. I would like to once again repeat the issue here. The cysts are present in the cortex of the ovary, and these cysts are nothing but the cystic dilatation of the follicles. So I can ask a few questions so that you can remember them. In the polycystic ovary, which hormones are elevated? Estrogen and androgen, and LH, luteinizing hormone. Which hormone is reduced? FSH. So what is the LH and FSH ratio? Increased. If I turn it over and I ask you what is the FSH LH ratio, then it is decreased. These are very important points. Since the patient has a high amount of estrogen, what are the complications may arise in this polycystic ovary? Number 1, endometrial hyperplasia. Number 2, endometrial carcinoma. What is the physical appearance of the patient? This patient is having a normal growth, but the patient is obese. Patient has a male-like secondary sexual characteristics. So it is almost like a normal female who is having amenorrhea or oligometrorrhea or oligomenorrhea. Patient is obese, high amount of estrogen, has the features of infertility. So this is the picture of a polycystic ovary patient. In a patient who has a Sertoli Leydig cell tumor, what are the features? Patient mostly short, but the patient has also the hirsutism. You can see the appearance of a tumor in the sense the patient have a delayed menarche. So the Sertoli Leydig cell tumor versus polycystic ovary, that is something that we try to understand how to differentiate these two conditions. Sertoli Leydig cell tumor versus polycystic ovary. I can just tell you a point which should help you to differentiate. A polycystic ovary syndrome patient is a patient who is obese. That is a point might help you to differentiate these two basic conditions, but there are some other conditions as well to recognize these two conditions. A patient who has a Leydig cell tumor, for example, most of this patient may have a delayed menarche. Delayed menarche is not a issue or a feature of a polycystic ovarian syndrome. So can you tell me from this particular PowerPoint what is the treatment probably, what kind of management you would like to do? So the recent management is that they are trying to reduce the insulin level of the system of the body. So once we reduce the insulin level of the body, I think that FSH LH ratio will alter, and that will help the lady to produce a ovulation, and then all the problem will go away. Finally, I just want to conclude our lecture today by showing you this particular normal graph of the LH and FSH in a normal person. You can see this is the FSH ratio, which goes up at the peak during between 12th to 14th day of the cycle. This is the LH. You can see there is a sudden surge of LH at this 12th to 14th day. Basically what happens in a patient who has a polycystic ovary, that LH level is too high to produce a surge. So surge will not take place, and if the surge does not take place, ovulation does not take place as well. So finally, in the polycystic ovary, the growth of the patient is essentially normal, which can be altered in the Leydig cell tumor. Oligomenorrhea is present. In the Leydig cell tumor, you can get amenorrhea or delayed menarche. Hirsutism, infertility, both can be present in both the situation. Endometrial hyperplasia is a feature for polycystic ovary. Cancer of the endometrium once again is a feature of the polycystic ovary. So please study the granulosa theca cell tumor, which also can produce hyperplasia of the endometrium. And when there is hyperplasia of the endometrium, what is the clinical presentation? Patient will present with a hemorrhage. So this is all about our ovarian lecture. I hope that you enjoyed it. Thank you so much. If you have any question, you can talk to me in the class, or you can come to my office. Thank you so much.